Welcome to KIMEcast. Tony Mikla here. What we're about to watch is an interview with Dr. Brian Gilmer, who's an outstanding knee orthopedic surgeon in the Reno, Nevada and Mammoth, California area. So Brian's just coming out of the OR, literally has a surgical hat still on, so we don't have time to do a proper introduction, but it's a great conversation diving into the bare procedure around ACL reconstruction, as well as some other sensitive knee topics around knee surgery. So fantastic surgeon, fantastic conversation. Hope you guys enjoy it.
Just excited to be doing this. And as I've discovered more depth of what you guys are doing, I just have, so much more respect for the program and the system. And it's awesome. What you're doing is great.
Thank Brian, you. Thanks, man. I appreciate that. Thank you.
I think you're doing the thing that everybody imagines, but nobody does.
Yep. That's it. That was what we were passionate about. Is how can we do the right thing for people? Can we get them can we treat people like a pro athlete? Can we get them, good care on a more rapid scale? And then, help them escort them through the process of finding the right people to see if they need to see a doc, finding the right tools, and get them moving through it in a rapid way.
Yeah, I have this big phrase about demedicalizing people. You know what I mean? I don't really want you in this medical industrial complex, or, sometimes I sum it up in clinic. I'm like, hey, the clinic is for sick people. If you're not sick, don't come hang out in my office. Go do something better.
I love that. That's great. I mean, that's exactly right.
Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work.
And you see these young people who still have symptoms, and there's no takebacks there. And as we said, allografts are not very reliable. So the best thing you can do is heal your own tissue. And if I could, I would get them all to heal. If I had a magic wand, that would be my wish.
Oh, for sure. So when you go in there, what do you, obviously looking for a vascularized area, right? So what's your decision-making process? Does it have to do more with size, location, or both big determinants of what you might go in and try to repair, and obviously age of the patient?
Yeah, the classic thing is, I don't tell people there's, yes, no criteria. There's just things that are better candidates and maybe slightly less good candidates. And better candidates are young. They have peripheral tears, which mean they're up against the capsule in the red zone. And we can generally do some things to stimulate them to heal, microfracture the notch, or poke holes in the meniscus to stimulate bleeding from the capsule side. The radial tears are kind of the worst. Those definitely ruin my day. Root tears, I wish weren't even meniscus tears, because they're so different that I wish I could just give them a separate name, I don't know, elephants or something like that, because people think I have a meniscus tear, and I'm like, this thing has absolutely nothing to do with your average run of the tear, meniscal tear that your friend had trimmed out and was playing soccer 3 weeks later, or, everybody knows that somebody with that story.
Yeah, right. That's the greatest thing with patients too. It's so funny. They're like, yeah, well, my buddy had this, or we were talking about it earlier with back pain. People, I had back surgery 10, 20 years ago. Oh, look at your mug.
Look at that, man. Yeah.
I take this thing everywhere. Thank you for my mug. I use this every day. It goes to every OR, and it lives in my backpack. True story.
Oh, that's amazing.
Sweet. So that's what it's for.
But it's amazing. Nico gave me this for Christmas last year.
There we go. Merry Christmas, man. Welcome
Thanks.
to the club.
I'm glad to see it landed.
Uh-huh.
I always thought he was just confiscating them for himself at home there for a while. So that's
good. They're really
see my garage here.
Yeah, they're really good. I like the twist off. I mean, I know it's not a Yeti commercial, but I'm a fan.
Oh yeah.
That chug cap is amazing. The drinkability of that thing's amazing.
Yeah.
Yeah, they nailed it.
Sorry,
All right,
we were
cool.
talking about knees. We can get back on track.
No, it's all good. So yeah, well, tell me more about that root tear situation. Like where you approach that differently surgically, obviously, as far as how you approach it. Are you still able to fix that with more of a, like if you're doing a repair, more of like a dart strategy, or do you have to do something different there?
They're totally different. So I tell people it's like a hoop on a wine barrel, and if you cut it, anywhere at the root, at the attachment, the whole barrel falls apart. So biomechanically, these are the same as having no meniscus whatsoever. And the classic story is it can be an active person. Sometimes it's a little more of an overweight person, kind of usually in my age range category or a little older, often like 50s, 60s. And the classic patients, they say they stepped off a curve and they just had horrible pain, like their leg was broken. And when the meniscus goes, the contact pressure in the knee suddenly shoots through the roof. That force is transferred to the tibia. And so it's essentially like they developed a stress fracture instantaneously because the tibia is not used to accepting all of that force. So it's about a 60% jump in load. So it would be like you were walking around with yourself and then somebody threw, a backpack weighing half your body weight suddenly on you. You would suddenly become a lot more symptomatic too, right? You'd be screaming, and that's what these are like. So the patients are often miserable. That's the classic medial meniscus root tear. And we have to put sutures in those, drill a hole in the back. And right now, what we do, because they're way in the back, is pull them out the front and either tie them over a button and back them up to an anchor. Or recently, one company in particular has an implant that sits right below the bone surface. And so I think that may be better, but we're still working on these implants that prevent that from shifting, because those patients are toe touch weight bearing for 6 weeks. Ideally, if they're a larger person, I'm usually going 6 weeks. If they're a little bit thinner and maybe their knee is a little more neutral, not aligned in varus, then I'll let them go at 4 weeks and slowly gait train them. And this is something we can talk about too. I am modernizing a lot of my protocols now to get people, no matter what I did, it needs to be like, we're done protecting it at 4 weeks, and we need to be shifting into active rehabilitation mode with gait training so that when I see them back at 6 weeks, they're walking. And so it's a little off topic of root tears, but the root tears are really the ones that got me there, because those patients are so miserable. And then you put them on crutches or a walker for 6 weeks and you just watch people melt away, and mentally they're defeated, physically they're defeated. And I'm like, well, like the disease, it's like the treatment's worse than the disease at some point,
Yeah. Oh man, couldn't agree more. The meniscus is tough on that front. So tough. On the classic 6 weeks non-weight bearing, that's the hardest part, especially if we see it combined with an ACL or something. It's just, we use BFR and do everything we can to try to keep what we can get. But I think that's prolongs the rehab process as well, where they lose so much that it takes so long to build it all back. So if you feel like it's safe to get going earlier, that's, yeah.
What I'm doing now is, on the therapists who I have good, close working relationships with, I have this sheet that I give people, and it's a 2-week crutch weaning protocol. And it's, some people are super type A and they want it all laid out. So I'm like, here you go. Other people, I'm like, just give this to your therapist and you can start putting weight on it. But it basically just says within a week, you go up to 50% and you go down to 1 crutch. And by the second week, you come back. And here's the kicker. So typically they're following up with me at 6 weeks. That means they're happy when they see me because they're walking.
Yeah.
First, they waited 6 weeks and it's just like deer in the headlights. And they're like, this is the worst. And I have to spend all this time talking people off a cliff. Whereas if they've done even a little bit of weight bearing, they feel that forward progress. And they're just like, okay, now I actually feel like I'm getting better.
Totally. Yeah, it's so true, because I think there's like a dead period. It gets like 4 weeks, and then it's kind of like, I feel good enough to go, but I gotta wait 2 more. So I mean, I like where you're at there. I think it's, without having seen the inside of the knee on the patient I'm working with, it always feels like, man, I feel like if we maybe just were stuck in extension, we could do this. If we limited to like extension only weight bearing. But what brought you to feel like you could push it a little more? Was it something in the healing process, or you just started seeing results that was working?
I take care of some pretty aggressive patients, and the best thing about those patients is you learn so much from them, right? You're like, here's somebody who's completely non-compliant. I'm like, this is fantastic, right? Because I'm going to learn what's possible. And what happened is I'd see these people. This is a very small town in Mammoth Lakes where I work, and it's a ski town, and you'll be riding chair, and I'll see somebody, I'll be like, hey, what are you doing? And they're like, oh, nothing. So you learn from people, and you're like, okay, well, I guess you can do this at whatever time frame, right? So I have a few people who push it, and they're just like, yeah, doc, thank you very much, but I'm going to do this, and that is becoming more of a phenomenon, I think, in the modern era, and so it's a push for me too. I mean, and I have, and then in follow up, I have not seen a ton of failures. So then I'm like, okay, like maybe this is the place we can push, right?
Yeah, totally. Yeah, I think it's great. I mean, I think it's interesting patients nowadays. The education is so high. Like there's so much information available to them, through the internet, to every other system, and they can communicate with people all over the world. They get on a Facebook group, or they're like, hey, well, how'd you guys do it? Or what'd you do? Like, my doctor did this, or I just started walking on it and said, screw it. I did great. And they're like, hey, I'll try that. And then, so I think the speed at which they get information is the typical way we've used to do it, where you guys, you operate, maybe you do a post-op a week or two out, and then you see them again at 6 weeks. Like, man, they're getting information every day in today's day and age. And that doesn't work for them anymore.
Yeah, I think surgeons are generally behind. We're, as a class, we're not always the most tech savvy population. And I think we're just a little bit behind. I think our technology has improved. I think a lot of things are possible. But I try and I call them standard protocol and accelerated protocol. In reality, they might be called, like, the accelerated protocol is actually the standard protocol, and the standard protocol is like, I'm super nervous, we're going to go slower, but I'm not going to call it the slow protocol. I'm going to call it the regular protocol, because if you feel like you're on the accelerated protocol, that's awesome, right? You feel like you're beating the curve somehow. So it's about how you pitch it too,
Totally. Yeah, I know you're not a shoulder guy anymore necessarily, but this is a great one just to give you some the perspective on that. We had this kid. It was probably like 2008, 2009, like thermal capsular shift, first of all. So that's usually not practiced anymore, and kind of frowned upon to some degree. So he comes in, and you guys made the protocol and stuff, and it's in a manila envelope, and I pull it out. It's the 1979 NEAR protocol. I'm like, do we realize that this was done in the orthoscopy wasn't even an option at this time? Much respect for NEAR and what he did, but this is an open procedure, rotator cuff repair. You're doing a capsular procedure that wasn't even in existence when this was created. It was amazing.
The surgeons are really bad about the protocols. And I'll be honest with you, a lot of them, I'm actually creating a website right now that will have those patient protocols. So what I do, I have the manila envelope. It's actually white, but I draw the patient a picture of the repair on the back. I write any handwritten notes to their therapist. I write my cell phone number on it. And I draw them a little picture, and then I'm like, here's how it went. This is what you had. And in the inside, there's a post-op instruction sheet, tells them what to do for the first 4 days, because a lot of them are just freaking out till they get to PT. And then I have their protocol in there, and that's the protocol that I'm like, just give that to your therapist. But I have a lot of people copying those protocols, so I finally just I'm making copies where you can just get on and download, and you can slap your logo on them, because nobody wants to like take my protocol and put their name. So
white label it.
Yeah, so it's basically just going to be label free. Hey, like, you can assign your own thing. But a lot of these protocols, it's taken years of like, and we still don't know, you know what I mean? And what do we do when we don't know? We tend to be conservative instead of aggressive.
Mm-hmm. Yeah.
Brian, has there been a protocol you've changed a lot recently? Any specific procedure or any specific type of injury that you've really adapted as of late?
Nico, this came up today. I despise braces after MPFL reconstruction, and I despise how slow the protocol is, but I can't get people off of it. Like, because we were doing it the old way, and now I'm like, throw away your brace and walk. And they're like, I just like, where's my brace? And I'm like, we don't need a brace. Like, we don't need a brace, because it's so hard. You come back and they have all this quad inhibition, and then we're just burning time waiting for their quads. And I'm not super nervous that they're going to dislocate again. I'm really not. So that's one. If I was ruler of the world, I would make that protocol a lot more liberal across the board. MPFL, isolated MPFL, or I don't know. What do you guys see? What knocks people down the most? It's not ACL anymore, because everyone's kind of agreed that we can do more with ACL. But now it's all these other things like MCL and MPFL, and you just watch their meat just melt away.
Yeah. That MPFL one, I was working with Hunter Green on that several years ago, and Hunter was the same way. He nicked that like a long time ago, like 10 years ago. He's like, he goes, go fast, get him out of the brace. We're not even going to issue one. They do bet. The harder you push it, the better. And I found that to be true. I mean, I've rehabbed tons of his over the years, and man, they get stronger, faster. That's confidence. Everybody wants to feel safe. So I think that's the hardest thing. But the best thing we can do for them is get their quad going. If we don't get the muscle strength back up there in a worse state off than anything else we could imagine.
I have a guy who's had a couple of revision surgeries, and I took care of him recently, and he has so little muscle. And he's, I've just watched his function decline, but it's all dynamic. And so it's like, guys, there's not a surgery for this. Like, you've lost so much muscle. It's almost, impossible to recover from that. Because now you're in this vicious cycle where you feel unstable because in fact you're weak, and you feel weak, and because you're weak, you're unstable, but you can't really ever escape from that, right?
Yeah, 100%. That's it. You got to uncycle it. I had this young girl just recently. She had MPFL, and she had multiple subluxations, dislocations prior. She's only like 13, actually 13. She was quite young. And she ended up doing really well with the whole thing. But the beginning was really, really slow, and she was super fearful about what to do, being out of the brace. Thought it moved on her a little bit, so she got really hesitant, and then sought a second opinion, which ended up being Hunter. And he's like, "No, it looks great. Like, you're only like 4 weeks out. Like, just, you gotta go. Let it go." And then like the next day, she just like completely shifted mentally. Like, "Oh, I could use my leg." And I'm like, "We've been talking about, we've been doing this for 4 weeks." Like, but she's like, "Oh, but now I have approval from someone who knows what they're doing to do it," which is, great. But it's amazing the mentality that goes along with the protocol. For the patient is huge. So I think it's a big deal.
Yeah, anxiety is probably the biggest enemy that we face these days, and it is the new pandemic. And oftentimes we can reassure people, but sometimes there's no amount of reassurance that even turns the tide. People have either been afraid of it for a very long time, and so we're fighting against, like, oh, hey, you've had symptoms for 2 years, so there are neural patterns that are firmly established that everything sucks and that you can't trust this thing. And I don't know how you guys do that, but I mean, that's what I can't give people, other than the Hunter Green, like, it's okay. Like, it's okay.
Yeah. Go with it. Yeah. You mentioned about the protocols, like what we do. And I think obviously we use the best science, and, we use the protocols issued to us by the surgeons at the end of the day who make the choice. But I think it's hard. There's every patient's different. There's so many variables. In our field, Kevin Wilk has been the godfather of physical therapy in sports for 30, 40 years, and he was putting stuff out there a long time ago with, of course, he's working with Andrews left, all day long, and they're doing their rotator cuff repairs. And back in the day, their slap repairs and stuff. And, on day one, he's ranging them 120 degrees. And you've got to, most surgeons at that time, back in the early 2000s, would have freaked out if you went past 90, and here's Kevin on day one at 120. And he's like, what's going to happen? He goes, it's fine. Like, it's actually slacking the muscle. I'm moving it for them, this and that. And they got unbelievable results. Obviously, they had unbelievable genetically inclined patients as athletes all day long. But a lot of his work really kind of pushed a lot of the away from the fear, at least in our space and field. But I think there's a consideration of obviously the person's age, their tissue quality, which I love to get from you guys. Like, when you get in there and do a repair, to be like, hey, what do you think? Like, can we push this one a little bit? Would you rather, maybe they're a smoker and they have diabetes? Maybe you felt like the tissue just wasn't solid. It was hard to get a good bite. So maybe you just be a little slower. I think that piece of information is really paramount and probably should determine the pace at which we go more than anything.
Yeah, in the knee world, there's less of that, right? There's some say with Bear, although I generally put all of those in the same category. But because we're reconstructing a lot more, I think we can be more aggressive early in the knee. And even when we are repairing, we're generally repairing like really robust tissues. So it's different than rotator cuff in that sense.
You say that when you do a reconstruction, you feel good about it. Is that because of the bone marrow leak and they get it into the bone a little more? Is that part of that, or where's that come from?
I just think the fixation these days is really robust, right? Like, when we're doing a reconstruction, I have good fixation of the graft on both ends. Whereas a repair, like you said, maybe the tissue quality is a little poor, but when we're adding collagen and it's good to go. Like, so that's led me to push a little bit. The weirdest thing about the knee is quad inhibition, though. You know what I mean? Like, you can do a knee replacement and someone can do a straight leg raise. You can drill a hole the size of my pinky, do an ACL reconstruction, and they can't leg raise for like 3 weeks. I don't understand that. I don't know what that is.
Yeah. I don't have a good answer for you. Nico, you got that one?
No idea. No clue. Yeah. I mean, it does, but it's one of these almost like viruses that just plagues that whole surgery. And it's always so challenging. Some people are so much more challenging, and you do everything possible and it's still lagging behind. And you see somebody that has a huge traumatic surgical process through a knee replacement, and they're fine.
I know. Yeah. I don't know. There are, like I said, there's still things that baffle me every day.
Yeah. I know there's a mental component. I feel confident saying that. I know there's a swelling component for sure. And other than that, I'm not sure. But those two things seem to definitely play somewhat of a role.
Brian, could you talk about like when you're... Go ahead.
No, you got it. You go.
When you have a patient come in and you're trying to decide between Bear versus a reconstruction, what kind of aspects, everybody here is fairly familiar with it, but everybody that's listening, that's not familiar with it, could you walk them through that thought process there?
Oh, sure. So Bear implant is Bridge-Enhanced ACL Repair. The idea is that if we every ACL tear goes through a process where it attempts to heal, but because it's in an aquarium in the knee and it's surrounded by synovial fluid, those cells, often people say, those cells can crawl, but they can't jump or they can't swim. And so that stump, unless it's reapproximated, that, there's nothing like the ACL is the only structure in the body that doesn't try to heal itself, right? I mean, everything makes an attempt. So the bridge, it's just how successful that body's attempt is. So the concept behind the Bear procedure is, if we create a hydrogel, basically we call it sometimes in jest the marshmallow. And if you fully hydrate a bear with blood, it makes like a gel. It's kind of a jelly bean. And what it does, it also makes a plug that seals off the notch, and it seals that synovial fluid out. Now, when you're an embryo, your notch in your knee is developed by the presence of the ACL as the knee moves back and forth through a range of motion, and that's what makes the notch. We know this because people there's a rare condition where people congenitally are born without ACLs. They don't have a notch. So the notch forms in response to that. In the bear procedure, the ACL remodels as we move the knee, and that fibers cross, but that gel kind of goes through a remodeling of a range of motion. So as we bend the knee, it leaves this sort of tubular structure, and the cells actually cross it. And we have some second looks now, which is when you have to go back and do surgery again. And it's unbelievable. It looks like native tissue. So it's really remarkable. We're still figuring out some of the details, optimizing the implants, optimizing the tension, optimizing how fast we can move. But what we've learned already since it came out in 2020 is that we can go a lot faster than we thought we could early on. That's a lot about the bear, but I might not have answered the question. Oh, how do I talk to him about it? So I need a stump on the tibia, preferably what's called a Sherman type 2, where most of the fibers are most of the way to the femur. So I have lots of stuff to sew to. We have done some type 3. Nico in particular has a patient of mine who is one of those patients I learned from, because wouldn't have been my ideal candidate. But joint decision making with the family, they're like, hey, I've had a reconstruction in our family and I want no part of that, in this case for my daughter. And family came together and decided, let's do this. We did the repair, and it totally worked. So FDA approved for any time you have a stump on the tibia. Now FDA approved. It was originally only FDA approved up to 14. Now it's approved for pediatrics, which is good, because the idea is if we can catch more of these younger people, and when you look at ACL repair alone, the literature tends to favor the younger patients actually heal better. Right. But what we worry about is that those same patients can have a successful procedure, but they're also the same category that's higher risk for a re-tear, no matter what we do, just because they're 14-year-olds playing year-round soccer or whatever it is, right? Or gym or volleyball or baseball. And their risk, therefore, is higher than my risk, who skis recreationally with my kids. Oh, I lost you.
No, you're still there.
Okay. So that's the conversation we have. But again, the one thing we're learning is that time is tissue, and if we can get to them within about 6 weeks. So a lot of times it's tough, right? They have the injury, they let the swelling go down, they do some prehab, and they come see me, and we get the MRI, and like the clock is kind of ticking. And so I want to, just like you're surfing, I want to catch that wave where the patient's not in the acute inflammatory phase, but they're still mounting that inflammatory response around 3 to 4 weeks, and the tissue's trying to heal and remodel. That's when I love to get to them. So I like to find them right away. I get them in some prehab, or give them prehab handouts. I get the MRI. We make that decision around 2 weeks, and we're doing surgery by 3 to 4 weeks. Whereas traditional mantra is you wait 4 to 6 weeks because there's a higher risk of arthrofibrosis if you go sooner. So that's fine. If you're doing a reconstruction, you want to wait. But if you're going to do a repair, we need to go early. And that means we need to be able to push for motion early, because we're riding the wave. We're not still out there bobbing in the ocean, if you will.
Yeah.
And then, so classically, Brian, are these younger population, middle age? Like, is there an age cutoff that you look at, or is it just health of tissue? What do you look at there?
It's really driven by my practice, and my practice is a lot of not the classic teenager field sports. It's skiers, and skiers tend to be in the category of like 20 to 40, and it's a seasonal sport. And so the most common month for an ACL tear in skiing is March, when the snow starts to soften. Mm-hmm. So the nice thing, we do a bear, that person gets to enjoy their summer because they're hiking and doing inline activities, and I want them doing all that. And they're skiing in December. So that's great. And they feel like they have a more native feeling knee. Whereas the reconstruction people are often they're fighting their quad atrophy, to be honest. It's not because their knee's unstable.
Yeah.
I go back and I look at those patients, and I get occasionally having a reason to go back for surgery, and I see grafts, and they also look really well healed in. But functionally, those patients are not in the same place as the repair patients.
Can you see what you need from the MRI then? On the MRI, you can see the stump that you need and know if it's the right option.
Yeah. So what we do in my practice, if somebody from out of area wants one, we do a telehealth visit, and I just say, you mail me your disc or file share it, and I look at it. And I've had 2 cases where I went in with a plan to repair and came out with the reconstruction, and they actually, in only one of those 2 cases, had to do with the tissue quality. The other was the patient had actually had poor bone quality, and when I put the anchor in, the anchor didn't hold, so I had to adjust what we were doing. So pretty much, yeah, like I'm not too terrified of the tear pattern anymore, and I'm in the probably 50 to 60 range now.
Nice. So, a lot of times when I'm talking with other orthos or other people, everybody talks about how, it hasn't been around for very long. We don't have long-term data. I don't want to be the test dummy for this. What is your answer and thoughts towards that?
I tell patients that, and just like there's the person who says, I don't want to be the test dummy, I also have the patients who say, I totally want to be your test dummy. And so it is, I tell people sometimes it's a bit of a personality test, right? And the sun moves in this room. So I tell them it's a personality test. And would you like a more natural feeling knee with a 20% chance of lifetime re-tear? Or would you like maybe a 15% chance of re-tear with a reconstruction? Maybe it feels a little less natural, but that is the lowest probability that we're ever back doing this again and like having the tearful visit with the Kleenex. And so then people will have different answers to that question. And so in 2025, that's what shared decision making looks like. My job, I tell people this all the time, my job is to give you information, and your job is to make decisions for your life and your body. And, I'm going to do everything I can to make it work, but it's not Burger King. Like, it's not the same thing every time. People are different.
Completely. Yeah, it's good.
Not to be unfair to Burger King. I like Burger King's fine.
Burger King's slogan. It's funny because when I teach, I use a slogan from them too. Is that it's your way right away, right?
Yeah,
so
totally.
They get to make they just make the choice.
I have to. I completely have to incorporate that now.
Yeah, it's like it's Burger King
episode
therapy. Have it your way right away.
There you go. Have it your way. Yeah. Oh my God.
100%. So if let's say you decide, or the bear's not an option, so you go the reconstruction route, what are you doing there? Do you have a preferred strategy or approach? All inside.
Well, here's
stuff like that.
Yeah, here's something interesting. This has evolved with time. So, surgeons are product. A generation of surgeons is about 10 years, right? A generation of humans is generally about 20, but a generation of surgeons and a way of thinking tends to be about 10 years old. And so I came out of training in 2013. Hamstring autografts were super common with a suspensory button and a plastic screw in the tibia. That was what you did. And then in 2015, because we were taking care of skiers don't really love losing hamstring control and deep knee flexion. So we were very early adopters of the quad graft. People are always like, oh, BTB. Yeah, again, I just don't take care of a ton of high level, like D1 football players. If I did, I would totally do BTBs, because if you're in the NFL combine, like that's what people have. But I think it's a cultural thing more than it is a quality thing. And it's just that this is what we do in that culture in that little niche. So in the skiing world, you're going to see more bears because they tend to be type 2 tears, and you're going to see more people doing all soft tissue quad. I'd say the biggest change in my practice in the reconstruction world, and I can claim no credit for this, we used to do the allografts still with ankle tendons. And then one day my PA, we went to the freezer to get a graft, and she's like, there's a quad graft in here frozen. She's like, do you want me to just make you that same thing we always love when we do autographs? And I was like, oh, like, yeah, why don't we just use a quad allograft? And eventually this company that sources them, it's a nonprofit company, because it deals in human tissue. It's named Allosource. They reached out and they said, do you know and I'm not the world's busiest ACL surgeon by any means. There are people who do a lot, but they were like, you're one of the top using quad allografts. I'm like, that can't possibly be right. And they're like, no, it's not that many. They said nobody is using these things. And so if you look histologically, the ACL has two different types of fibers under a microscope. A quad graft has two different types of fibers under a microscope. The biomechanical properties are more like an ACL than those other grafts. Its stiffness and its function are very similar to the ACL. So I've been loving quadriceps allografts. I have a far-reaching dream, that someday we won't really be harvesting autographs anymore, right? That we can use allograft, cadaver tissue, and biologically augment it to get the same healing response and the same re-tear risk without hurting people. Because rewind this conversation 20 minutes, we're sitting here talking about how it's the graft morbidity that hurts people,
Yeah. Yep. Slows them down 100%.
So I have a dream we're gonna biologically augment allografts when things aren't reconstructible, and that patients will either get a repair of their own tissue or they'll get a reconstruction with a graft that's biologically augmented to stimulate it to heal.
Yeah. The allografts are way easier to rehab, no doubt about that. I mean, less pain, easy motion, easy to get strength right away. So they can't feel anything, but as long as it doesn't swell up on them, it does pretty well.
Right. And so, historically they were radiating them and doing chemical washes, and those things all weaken the properties, right? But it is just a scaffold. So if we can find ways to convince people's tissue to migrate into those grafts, we can win.
Yeah, when you say things like that, like biologic augmentum, maybe you don't know what that is yet, but is that something along the lines of like using PRP or stem cell or something in that, like injecting them, or?
Yeah, there's a concept, a guy named Chad Lavender kind of coined the term, but he called it, I think it's Chad who came up with this, fertilized ACL, where they basically are, soaking it in PRP, putting demineralized bone matrix in the tunnels, again, just to seal out they're just trying to seal out that synovial fluid that interferes with healing. And there was just a study in the Arthroscopy Journal that just came out in May. Full disclosure, I haven't read the whole study yet, but basically saying that their long-term outcomes are the same, these grafts, but their early recovery is better. That their outcomes are, and don't quote me on that because I literally was flipping through the journal and then my daughter jumped on my lap and I was like, I got to read that later, No, I gotta play Barbie. That's what I gotta do right now. I gotta play Barbie.
Yes, indeed. That's the game. No, I think that's what's so cool in healthcare in general, especially in surgery. I think that's evolved is the maybe more than understanding, but the ability to facilitate the healing process. I think has been amazing. Like to see the biologicals come along with the surgery techniques, like less collateral damage with the surgery. And then usually some sort of insertion of biologics or, drilling a hole that causes some release of marrow or something that stimulates healing. And then being able to leverage that. That's what I've seen in my career over the last 20 years is like a continual kind of progress in supporting the ways to heal, getting the tissue to heal better fixation strategies, better anchoring techniques. and then now biologics. It's pretty cool.
Yeah, I think we've kind of maxed out. I mean, we'll continue to innovate, but the mechanical side of things, we've got that pretty doggone good. There's several options.
Yeah.
They're all good. The biology, the classic biologic triad is cells, signaling, and scaffold. And right now we can get cells, and there are some people playing with scaffolds, but we're a long ways from figuring out the conductor of the orchestra who tells everybody to go to their chairs and when to play what. And that's what we haven't unlocked yet. Right now we're kind of just like putting all the players in a room, and the oboes next to the tuba guy, and so it's like, well, it doesn't
hope
work.
they figure it out. Come on, guys, get together and make music. 100%. All we have to do, we can figure out how to grow some cartilage and get that to go. That's where it's at.
I think that quest will probably that will definitely outpace my career. I don't plan to work until I'm like 100 or something. It will probably outpace most of my life, but I bet you within my children's lives, we get that figured out.
Yeah. I mean, that's the game changer for so much of the knee, for so much of the aging process. People lose that knee function, they stop exercising, start gaining weight. I mean, you see I think the morbidity associated with knee is a very general statement. I feel like is high. It leads to a lot of problems for people, and then they get arthritic, and then the replacements are amazing. But most people want to push that off as far as possible. But I think those are huge lifestyle changers. But it'd be nice to have a solution for those folks that are like 30 to 50.
Well, a lot of those people come to me and they say, I want a total knee. And I have all these funny sayings, and some of them are maybe better than others. But I tell them, they're like, well, can't I just go tear it up and you'll get me a new knee? And I'm like, your native knee is a Porsche. And it might be a Porsche that's in the shop a lot, and maybe it makes some noises, but a total knee is like a brand new shiny Camry. And I'm like, so do you want to trade in the Porsche for a Camry? And they're like, oh no, I'm good with the Porsche. I'll drive the Porsche. And I'm like, because that's how it is. Like, it's great, but you're probably not gonna, take it to Le Mans. And right. So, and now that being said, some people, like in your world in particular, are so athletic that you can put metal and plastic in their knee, and they're just like, yeah, whatever, let's go.
Yeah, just as good.
Those people inspire me, but they're not the norm statistically. I
love your analogies, Brian. You should have a short
podcast.
Like,
yes.
Like when you make your website of protocols, you should have a page dedicated to these are the analogies to describe a meniscus. This is what you do to describe total knee. Be great.
I was actually thinking more like a coffee table book for surgeon trainees. You know what I mean? Like, not even coffee table. Like, let's be honest here, like a bathroom book with one-liners. You know what I mean?
Yeah.
That's about my level of literary achievement that I can target, I think.
The key for you guys is how can you get in front of you? Like you could obviously think like OR locker room, but you're only in there for like a second. Not even. And then you're documenting, and then boom, you're in the OR, hands dirty, and then boom, you're back in the clinic with patients. Like, how do you get in front of you? But if you can figure that out.
Yeah, no, that's why it's got to be scribbled on the bathroom stall.
That's the best way. That's the best way.
I think there's something there, Brian.
Cartilage is king, like just in the bathroom stall. You're like, you know what? That's true. That's true. Have it your way.
For sure. Yes, sir. Well, I expect to see these at the Mammoth conference. So you guys run a great conference.
We thank you for shamelessly plugging our conference. It's growing and it's changing. It's now no longer the Mammoth Sports Course. It is now the Mountain Orthopedic Rendezvous, MORE. It's like an analogy that didn't quite work, and so we had to tweak it. But the idea being that the idea being that now we can move to different mountain towns. because that's really what we are. And everybody learns from mountain athlete and mountain communities. One, they're small encapsulated places. You got really good follow-up. You get one complication, you might as well have, everybody's like, oh man, Gilmer's he's had 20 complications. Like, no, man, just one guy hanging out in the coffee shop for one day,
Right.
But it's a great venue, and it's just like this, is super interactive. And we do a lot of interaction with the therapist, because it's like, okay, we present the cases, and then somebody stands up and they're like, let me tell you how that actually went. And then, we get all the feedback from that. So I think everyone learns a lot. So thanks for mentioning it.
Yeah, no, I heard it's intimate. A good friend of mine, Brandon Beamer, when he was here in SAC, used to come down. Man, he raved about that. Big Stanford guy, and he's like, man, this Mammoth conference is awesome. He loved it.
Well, and now he lives in Montana, and he made the decision to move to Montana while having dinner with his wife after the course. So that's a true story.
That is true.
Wow.
Yeah. So maybe that's a future location up in Bozeman. And
I'm
qualify as a mountain town.
They're on the list. They're on the list. And I'm sorry if I drew him out of Sacramento. I apologize.
Well, it hurt me temporarily, I will say, but Brandon definitely is on his own path there to do what he's doing. But he's a great surgeon, a great guy. I'm happy for him to make that launch. It's been good. He's having a great time. He's got antlers on the wall like you. I saw back there. He had some antlers on the wall, man.
That's so funny. Well, the Montana antlers are going to be a lot bigger. This is just our little Texas ranch where I grew up, but it's not exactly like elk.
Yeah. He gets some big stuff. This is so years ago when the fires were here. There was the fires were bad one summer, and he was at an operating day, and the power went out, so BJ shut everything down, and the hospital was all in backup, but he was operating a surgery center, and they didn't have to do it, so they canceled all his surgeries. So he was irate, right? He's like, what are you thinking? He's so mad. And then so he sends me a picture about 2 hours later with him with a deer. He goes, I had to make something bleed today.
So funny. And
this is one of my favorite ones ever. Yeah.
That is,
so classic.
That's classic. In the smoke, no less. Yeah, I don't miss that. I guess that season is coming up, but protect us all here in the Sierra.
Hopefully it'll be all right. All right, so people can find you. You're in Mammoth, and then you're also in Reno as well, right?
Yep. And the easiest way to find me is just briangilmermd.com. Also on Instagram and various socials, where there are additional rants on all things knee related.
Good. You should have like a Friday analogy section or something in there. Just slide them in.
I'm gonna tell my marketing person that. I will let her know.
We'll see the Burger King one tomorrow, I'm sure.
I don't know. I'm always nervous. Someone's going to take it too literally and like show up in my clinic. Like, I thought you said I could have this today. I'm ready right now.
Let's go.
Yeah, let's go. Well, thanks for the invite. Brian,
it's been fun. Hey, man, absolutely. Thanks for coming on and talking shop. This has been great. I learned some things from you, so I appreciate that every time.
Well, thank you, Nico, and thanks for taking care of our athletes in town, and we'll see you guys very soon.
Yeah, thanks for everything you do, Brian. Really raising the bar here, so it's always a pleasure to work with you.
I don't know. I'm just trying to keep up with you guys.
We'll push each other.
Fair enough.
Thanks, Brian. You have a good night. I appreciate it.
All right. Adios.